Do you need to mic me?
I do. Unfortunately, this is a dual mic scenario. Sorry about that.
What does that mean?
Well, did you wear one for your last presentation? This one's for the recording.
Okay.
The other one is for the room. So if you
Okay.
can project loud enough, you don't need to wear two.
Okay.
Wear one for the recording. So,
So this is the one for the recording.
and for the broadcast.
And you know what? I was not thinking when I put this dress on. I didn't know where to hook it to, and no pocket,
Is it something you gotta
nothing.
talk about in the office? You just need a little belt.
Like I just didn't even think about that. All right, so this needs to go here. Am I right?
And it's already on.
I don't know. I guess I'll just hold it hopelessly. I don't have anywhere to. I have nothing on this dress. Nothing.
If I had a little petite belt myself.
I guess I'll have to talk loud because I don't. I can't carry two of them. You know. I should think these things through. Okay. So they have two mics, one for the sound, for the video, and one for the sound. And I have no where to hook them onto my body. So
Really bad back and play. If it's important.
I tried really hard to look nice today.
Right.
Maybe undoing all of that.
Yeah. Totally ruin everything there. Okay, that's a small thing.
I think I'll just talk loud. Is that all right?
Yeah, absolutely.
But I might get somebody to forward my slides for me so I don't have to stand in that hole. Because if I'm standing in the hole, of course.
Wireless.
Oh, there's a wireless. Okay. The only thing about this is that I like being able to see my next slide, but I can just turn it.
Well, the problem with light here. Actually, I did have it over there, but I just once I get started.
Can you put it over here? That's great. As long as I'm not standing back there, I think just my voice is probably loud enough.
I would say.
Okay. Oh, I'm so tired. Oh my goodness. All right, so is it this arrow button?
That's backwards.
Oh. Okay.
And I went ahead and pulled up your YouTube link.
Oh, did you?
I did.
Okay, thank you.
This is the audio on it and everything. So I guess when you get to that slide, you have the, you can't like click on it. You have to come over here and jump out of your presentation and go to YouTube and play it. Or I could close it and you could leave it and just click on the link and it'll open automatically.
Okay, so when I get to that slide, I'll just come over here, click, do I just minimize this?
You can go forward so we get to it.
There it is. Back it up one. There it is.
Over here.
Oh, did you just move the mouse and click on it? Is that what you did?
Yeah.
Where's
The
the
demo
sound?
checkup has been
Can't make it stop.
demonstrated in really strong randomized
So it might
controlled
be better
trials
to
with lots
exit out
of
of it. Go ahead and play it. And then switch back.
Okay.
Well, that's it.
So
If you
all I'm
want-
going
if
to
you want, I can
do,
do it for you.
it's all right, I'm just going to minimize this, hit play, and then come back down here and,
Select that one, and then you're back up.
okay, that sounds good. Beautiful, thank you. Now I am. ready. You can. I just had to do something about my lips.
So we're pleased to have Dr. Jodi Polaha here to present pediatric runrounds on placing the family checkup in integrated care. Dr. Polaha received her doctorate in clinical psychology with a specialization in child clinical from Auburn University. She came to ETSU in 2006 from the University of Nebraska, and I noted in your CV that you had run a Rural Health Award for integrated care while in Nebraska, and that has really been a big focus of her career at ETSU, and she's really become a leader in that area. So we're happy to have her here today. She joined ETSU in the Department of Psychology, but just this past year has relocated into the Department of Family Medicine. She also is sort of part-time in the ETSU Department of Pediatrics. She's published dozens of papers and presented many dozens of presentations in her career, and has worked in our clinic, I want to say for about 7 or 8
Yep.
years, really helping us to establish integrated team care, first with psychology and now also with social work, and has helped the clinic address many health topics like ADHD and postpartum depression, behavior problems in children, using this integrated care model. I'll turn it over to Dr. Polaha. Thank you.
Thank you, ma'am. Well, I'm really excited to be here today, and I hope I brought a little bit of something for everyone. This was a challenging talk for me to prepare. I talk frequently, and I'm usually delivering some sort of training about some existing literature or evidence-based treatment. Those are easy talks to prepare because you just read the literature and you kind of know stuff from practice and you build it all in. This is actually in part, this talk is going to be in part the results of some recent research that I've been doing that's really kind of hot off the presses. So in the last 4 or 5 weeks, we've been analyzing data, and even as recently as last night, I was looking at some new analyses and thinking about whether to build some of that data into the talk. It's a little harder when you're trying to really try to digest some new data and think about what the audience would really be interested in hearing. Hopefully there'll be a little bit for people who never heard of the family checkup or don't know much about integrated care, and there'll be a little bit for people who know all about this particular study and want to kind of hear the outcomes and learn maybe some more of the nuances. So it'll hopefully all be in there. I have nothing to disclose. I do want to acknowledge the team of researchers who put this project together. Karen Skatsina, who just introduced me, from pediatrics, and Katie Baker from public health. We were awarded a grant from the Research Development Committee at ETSU that funded most of the study, but we also received funding from the Vice President for Health Affairs in support of interprofessional education, and the Department of Pediatrics supported this project by paying for our student stipends that provided the family checkup to patients. Speaking of student support, and I also, before I start, want to thank Cami Kwong and also my students who have really helped me deliver this intervention and get the data ready and really roll out the project from just a pragmatics perspective. Speaking of my students, one of them is about to freak out. And her name is Brandy Manis, and she's sitting in the front row. And I did not ask her permission to use this photo in my talk. This is a day in the life of a behavioral health consultant in pediatrics. I had my students keeping data for the last 2 weeks. What do you do all day? This is not all the things that they do, but these are all the patient contacts that they had. So we talk about handoffs. Those are people who were in for an acute care visit or a well child visit, and in the context of meeting with their primary care provider, raised an issue that's pertinent or germane to behavior change, and she was brought in, spontaneous kind of handoffs. And we also talk about scheduled visits, and those are people that she maybe has seen before and they were scheduled to come back and follow up, or they may be people that were referred at another time to come back and see the behavioral health consultant. What do you all notice about the kind of business that she's doing, just in looking at this list? There are kind of two, to me at least, there are 2 or 3 sort of characteristics here. Very broad practice, right? So she's kind of seeing all comers and a wide range of presenting problems. In fact, this is almost the perfect list of the top 5 problems that present in terms of behavior concerns in primary care. We know from many studies looking at the data in 17 different ways, from case reviews to sitting in the clinic visits and taking data to asking parents in the waiting room, that about 25% of kids who attend regular old pediatric primary care visits have a behavioral health concern, and most of them have one of these kinds of concerns: behavior problems, ADHD, sleep, feeding, or developmental delays in autism, which that last one's not on there, but that's one of the top 5. We also do a fair amount of business, about maybe 20% of our business is in other kinds of concerns, like separation anxiety, school refusal, kids with habits like thumb sucking or hair pulling, pediatric pain that we can address through behavior change strategies, adherence to medical regimens. Those are all kind of other business that we do that keep us pretty busy. But we do a very broad and diverse practice. We practice as generalists. We see all comers. Anything else that you're noticing there? I would argue that she stays pretty busy. This is a pretty good sized caseload when you add in the phone calls and individual hallway consults and some of the other business that she's doing throughout the day. So this is a day in the life. And I'm going to tie that into the family checkup as I go forward. I want you to know the model of integrated care we're practicing as the context for the family checkup. And the day in the life of Brandy or Jessica really help you get that. We'll discuss the family checkup specifically and how it fits into that model. And then we'll talk about the outcomes of the small pilot study that Karen and Katie and I did. And then I will try to figure out which future directions I feel like talking about, because I have a long list. So just very basically, integrated care in pediatrics is this systematic coordination of care. We've just talked about that a whole bunch with the residents. I think it's important to, can I ask you a question? Are these the slides I emailed? I made some changes. Sorry. Is it okay if I pull it up really quick? Sorry. Debbie, are they on the flash drive? They're on that flash drive. I'm just trying to think if I need to do that. Yeah. Yeah. Can you do that for me? Sorry about this.
Are you going to talk about this tonight? Is that going to fill time?
Yeah, fill a time for me.
Well, I was just going to mention while you were getting your slides together, didn't mention it when I introduced Dr. Polaha, is
Come up here so people watching from clinic.
I don't want to take her.
No, keep going.
While they're fixing the slides, I just wanted to mention, in addition to this research project, Dr. Polaha is helping to lead a pretty big team of investigators on a HRSA grant. It's a 5-year grant for implementing team-based care in primary care, as well as training people to practice team-based care. And we have just started this grant. It's very related, of course, to this project that she's going to describe. But that is something that's going to be going forward and bring a lot of resources to the area to help us do that even better in pediatrics and family practice clinics for ETSU in this area, and involve psychology, public health in addition to other allied health specialties like nutrition. Did I fill time?
That was awesome.
Did I fill
It's
enough
like a little
time?
infomercial right in there. Thank
so
you, Karen.
this is all going to be really relevant going forward as we build on this work.
And as I was preparing to talk, and Karen was in the audience, and then she was introducing me, and I was just having one of those like sort of blessed moments where I was like, how cool is it to have this collaborator? We've worked together on so many projects, and here we are again after all these years, and then here she is like running up here and saving me when my slides aren't ready. It's like, it's beautiful. It's like an epic novel for geeks. You complete. Thank you. That's what I needed. Just to sort of underscore again this integrated model that we've been striving for. Again, I'm trying to place the family checkup into the context of the model we're trying to promote in pediatrics. I was talking to the residents earlier. We're really shooting for this thing called primary care behavioral health, where behavioral health consultants function as consultants to the primary care provider. And that's who their primary consumer is, not the patient per se. That the care context is really a team-based context as opposed to specialty mental health, which is more autonomous. That we do an on-demand service rather than a scheduled, siloed service. We have a high level of productivity. Some of these things should have been noticeable in the day in the life of Brandy, as opposed to therapists in specialty mental health settings who only can see like 6 or 8 patients in a day because of their 1 hour kind of rigid system. Brandy could actually see many more than that because her schedule is not booked with 1 hour patients. We tend to provide a lower dose treatment, but keep a very wide problem scope and not necessarily wait until full resolution of problems to sort of release people from care, but just sort of see that they're making progress and keep moving so that we can really serve the patients at the pace that primary care works. We're really working in a primary care behavioral health model, if that makes sense. So that's the kind of platform. There's evidence for this platform. There's a lot of evidence, and there are lots of journal articles and references that I could cite here. I chose instead to choose one very recent publication. This was a meta-analysis published in JAMA Peds. They took 31 randomized controlled trials that looked at various integrated care models in pediatrics specifically and tried to figure out if this works. And the results showed that integrated practices had a significant advantage relative to what usual care is without integration in terms of behavioral health outcomes for children who got that. They found more robust results for kids who got treatment for a mental health concern than for kids who got more of a prevention style intervention, which is typical of the prevention literature in general. They also found that the studies that engaged or deployed a collaborative approach, that's this whole team model that we've been talking about even in this prior conversation today, got better outcomes than when that relationship was more consultative or co-located. So just having a specialty mental health provider hanging out in an office in the back somewhere doesn't get you as robust of a treatment response as if you're all kind of sort of working together on that. So the American Academy of Pediatrics has promoted integrated care as a standard, but I just want to underscore that there's some pretty good studies out there now, including 31 randomized controlled trials, which are showing some good effects of making an attempt at integrated care. The struggle at ETSU for me often feels like balancing on a tightrope while juggling, where we're trying to develop a system of integrating what we do into what primary care does. And specialty mental health practices very differently, as you saw in that prior table. So how do we adapt that to fit into this population-focused model? That's a system change. Kind of how do we just do it? How do we get this in here? And then the other part, the juggling part perhaps, is figuring out how the treatment, once it's deployed and fits into this environment, is still a quality, evidence-based functional treatment. We haven't stripped it so down to fit into this environment that it's not a robust treatment anymore, and we're not really getting good results with our patients. So it's great that we can be there for you. It's great that we can go right into the room. That means we've sort of done a pretty good job at a systems level of sort of retooling how we work. But if what we're doing with patients is so different from what we've studied and what we know works from the evidence base, then it's like we're robbing Peter to whatever that thing is. I won't try to say what that is because I don't know. Okay, let me try to do this. So I'm going to minimize this. I'm going to show you a little quick clip. Oh, it went away. No, it didn't. It's right here. I'm okay. I got it.
The family checkup has been demonstrated in really strong randomized controlled trials with lots of families in school situations.
Oh,
Parents
it wasn't on
coming
the
into
screen.
schools with their children to be seen in a family checkup. What we want to do is roll it out in a primary care clinic.
That is what these three researchers from ETSU will soon do, thanks to a new grant from the school's Research and Development Committee.
The family checkup is a very brief parenting intervention. Most people who think of parent training think of 8 or 10 weeks and groups and lots of really commitment to coming regularly and making lots of different changes. The family checkup is really cool because it only asks parents to think about, it's an assessment that helps them know what their strengths and weaknesses are. And then it asks them to think about what 1 or 2 changes they might like to make their parenting stronger.
The study will be conducted here at Quillen ETSU Physicians Pediatrics. And Quillen pediatrician Dr. Karen Sketsina says the primary care setting is the ideal place for conversations about behavior to occur.
There have been studies demonstrating that when parents bring their children to the pediatric office, up to perhaps 25% of the time, one of the concerns that they have is about their children's behavior, and they may or may not have the opportunity or time to bring it up during each visit, but we know that it is a common concern, and it's something that we routinely screen for during well-child visits. I like the fact that we have the opportunity to integrate it into the primary care setting because we are a medical home for children. During the first 5 years of life, we see families 12 times for well-child visits and annually after that. So it's a convenient place to address concerns about children's behavior for the parents.
From a public health perspective, epidemiological data show us that behavioral problems at a young age can actually predict risk behavior during adolescence. So we want to intervene with children exhibiting behavioral problems at 4 and 5 years old with the hope that we can reduce their risk of engaging in behaviors like substance use during their teenage years.
Baker says she believes the interprofessional approach of the study will result in improved community health outcomes.
Recently, we've changed the name of our Interprofessional Education Committee to the Interprofessional Education and Research Committee to encompass projects just like this one. This research project allows Dr. Polaha from psychology, Dr. Sketsina from pediatrics, and myself from public health to combine our expertise in a project we hope will be more effective than were we to go at it alone.
For ETSU University Relations, this is Chad Barrett.
You have to look left and steer right. And that's not a skill I learned in graduate school, I'll tell you that. Now there's me. I got it, man. I want to prove myself. But which one is it? There's 2 different ones there.
This one is where you left off.
Okay, very good. Nope, that's not it. It's the other one. Holy smokes.
I think you closed it. It's that right there.
Oh, you're right. Okay. Okay. So I wanted to give you all a sense of where we were a little over a year ago when we kicked this thing off. I also wanted an opportunity to have one more person angry at me for including their video data on my slides. But I also wanted you to get some perspective. So this is exactly the problem I was trying to articulate earlier. We want to fit into primary care, and we want to fit that system, but we also have to balance that with quality, right? So we really have to think about, if we're going to alter this treatment to fit into this model, are we making too many sacrifices? Are we losing some of the efficacy or the quality of the treatment? So the original family checkup was not developed for primary care. What was it developed for? Anybody catch that? It was the very beginning of that little clip. It's developed for schools. That's right. It was a school-based program. It had 3 sessions. A therapist met with a family and a child, talked about their family, got some rating scales filled out. In the second visit, went to their home, did an ecological assessment, kind of did some video data, had the parent and child interact, kind of watch some of that, and then had the family come back for a third appointment with feedback and sort of referral for follow-up services as needed. But those 3 circles, those 3 sessions really constitute the family checkup. And all of the results that have been published, and there have been many, many randomized controlled trials and other studies of the family checkup, have been based on just those 3 sessions. That's really the treatment that we're talking about here. It's a very brief delivery system where we really kind of figure out, like I said in the video, what are your strengths and weaknesses, and what's 1 or 2 like kind of low-hanging fruit that we can address. In my mind, that's a great fit or a better fit with population health model systems like primary care. It seems like a good idea to try to take this evidence-based model and move it into some of the things we're doing as an integrated care practice. So that's just what we did. As just a quick review, there have been so many trials with the family checkup that have shown improvements on or benefits on all of these variables. And I'm not going to get into all the data on the fact that the family checkup works, but it impacts child and family outcomes from really 2 or 3 years of age all the way through adolescence. It influences things like parent-child conflict, child behavior, child academic performance in young children, all the way through kind of adult or teenage risk behavior and substance abuse. And there's really good data on this. So it's something that you feel like you can kind of put your money on. It's a treatment that's endorsed by quite a few selected registries and funded by the top federal funders that are out there. So when we started thinking about how do we fit this into this sort of already existing PCBH model of integrated care we have at Pediatrics, one of the most important things to me was coming up with an implementation plan that would work. And so featured here are most of the people that worked with us, primary care providers, office staff, behavioral health consultants, and Katie, our public health people, all sitting down and saying, how do we take this 3-session intervention and move it into this practice in a way that can really work? And we met, this is just kind of a timeline of our activities. We met for the first time to discuss this in August of 2014. At that time, I was still just educating providers, like this is what the family checkup is. As we met again, this implementation team, we talked about what are the barriers you think to getting this implemented. And as I sketched out an adapted model, I got feedback from them. How does this sound? What if we do it this way? What do you guys think? Can this work? So trying to really be, and I'm in touch with the developers as I'm doing that, so that by the time we launch this thing, we really feel confident that we have something that can work. This is what we came up with. We decided we would administer the pediatric symptom checklist to every single 4- and 5-year-old that was coming in for a well visit. Anyone that scored higher than 15 would be referred to us, and those are the functions that the primary care staff would perform. Then once it came to us, we would do the assessment and the feedback and treatment, as well as the follow-up as needed. But we did not conceptualize this as necessarily a 3-session intervention, and we did not initially conceptualize it as having a home visit component. What we sort of hoped was that we would get warm handoffs, we'd be able to complete most of the assessment in the warm handoff, and maybe have them come back for one more visit. We were hoping to keep it very flexible, be able to kind of be patient-centered about what we included and what we didn't include in the sessions that we offered. And that seemed to fit. So not quite a year ago, but almost a year ago, we launched the family checkup. Actually, it's pretty close to a year ago. We launched the family checkup at ATSU Pediatrics. Everybody was on board. We had a big grand rounds before we did that. And then a couple of times since then, we've met to kind of look at the data and say, how is this going and what changes do we need to make and are people on board? So this is actually another opportunity for us to do that today. So here's some data. This is the practice's adoption of the PSC as a screener. So this is the top bar, the bright green line is the number of well visits that were seen in the last 10 months, and the orange line is the number that received a screener. So 448 4- and 5-year-olds have come in the last year, and of those, 335 were screened on the family checkup. That's about 80%. It's very interesting to me that the rate of screening dropped a little bit in July. Wonder if anybody has any hypotheses about that. We won't go there. I think what you're seeing in the beginning, we had a very high rate of capture, and then like in the last few months, it's sort of kept a slightly lower pace. I think what we're seeing there is sort of knowing maybe where some insurance companies won't reimburse for the screener, and we don't want that charge to fall on parents. So some choices about how and we still administer verbally some items. So the families are still getting checked out. They're still getting the service, but not necessarily getting the screener. So kind of how we've sort of adapted our screening model to adjust. So what's interesting about this is that of 330 people or so screened, we had about 30 children identified as having significant behavior problems. So about 9% of the total screened sample came up as having significant psychosocial concerns. Now, we know that number is lower than what our general prevalence of psychosocial concerns is. We've collected that exact same measure in the waiting room with all parents presenting for acute and well visits, and our number was much higher, like 16%. It's lower in well visits, and we expected it to be lower in well visits because people coming in for well visits don't have as many concerns, and that's actually documented in the literature. If you want to capture behavior problems, you have to include acute cases, because the fact of the matter is that naughty kids drive a lot of acute visits. And that may not be top of mind in a scheduled well visit, but it is when they're coming in with a sick kid or an annoying kid. Does that make sense to you all? So we don't capture quite the numbers that we would if we were addressing all acute visits, but we were okay with that. And I'll tell you, one of the biggest considerations in launching this was, will it be too big for the clinic? And all of the providers, including me, were worried that it would be too much business and keep us bogged down. So we intentionally scaled this back, and I think as we're looking at the results, we'll realize, well, we could have gone a little bigger with this. So 30 kids screened high, and that was pretty much the sample that we had to work with, except that we actually, well, I'll come back to that. Of 30 patients with high scores, 26 were referred to see us. So that's an adoption rate of the family checkup of about 87%. So that's great. That means that almost everybody that scores high is getting sent to the family checkup, which is what we trained everyone to do. And of course, you know, clinical impressions and judgment would anticipate that there would be a few people that would score high that would just not be good referrals for one reason or another. So I think that's an awesome adoption rate of the family checkup, and that's what you're looking at in this chart. It turns out, though, that an additional 9 patients were referred that were not high, but because of clinical judgment in those visits, it was felt like they would be good people to come in. So our total kind of sample of referred kids was 35. 26 referred through screeners, and additional 9 from just clinical judgment. So if you look at the flow there, you have 336 screened out of, I think that's supposed to be 448 visits, I'm not sure. 26 referred out of 30 high scores, 9 additional referrals. And what we have right now is 18 who have completed all of the assessment components to date. So looking at that in terms of percentages of uptake, you have 80% of the well visits screened. That's a good number for adopting the screener. 87% of high scores referred. That's awesome adoption of the family checkup as a treatment option. We have these additional kids, and what we have is about 51% of our sample that have actually completed the assessment. That's the reach or penetration of the intervention into the at-risk group. Does that make sense to you all? We talked about this in my resident lecture at 11. What's the number of at-risk kids that go to specialty mental health? Or what's the number of what did we say? Yeah, like 5 to 10%. So this is a much better reach. There's actually a significant difference between the kids that would attend services in specialty mental health and this group. Kids that would go to specialty mental health are kids and parents who are actively seeking treatment. And so they're very motivated to find some help. These kids didn't come in asking for this. They came in for a well visit. So in some ways, it's even more remarkable that we were able to get some treatment out to basically all of these people. Very few of them probably were actually seeking that kind of help. Does that make sense? And one more comment about reach here. In the trials I mentioned earlier that have been done in schools, the reach was 25%. So of all the kids in schools that were screened and identified as at risk, they were able to get 25% to come into all 3 visits. So we're actually doing a little better than what school-based prevention type services look like. Just some characteristics of the families that we've seen. About 40% have married parents, so a majority don't. About 42% describe themselves as having very good or excellent health, so about 60% describe themselves on the other end of that scale, which is sort of good or less, right? 40% are rated as having below average language skills, and 30% are receiving special services through the schools. So we're looking at a pretty needy population. That's what you would expect. We have a battery of measures that people fill out that takes about 30 minutes to complete. So this is part of that. Parent-child warmth or parent-child nurturing behaviors are something we assess. So if you look at that whole group that was referred to us, we have data on about 18 or 20 kids. You see a lot of parents sort of admitting that they don't have a lot of fun with their kids. They rarely invite their child to play with them. They rarely teach their child new skills, and that they rarely, or even maybe sometimes, speak calmly when upset, right? Oops, I didn't mean to do that. Then there's this issue of parent-child conflict. For this group that we're working with, quite a few often yell at or shout at their child. 16% report that they often or very often feel like they can't handle their child, don't feel confident, and 40% endorsed often or very often using physical discipline with their child. So this is a group that really needs our services. We don't have data on what other parents would endorse in this group that are not referred, but I think it's interesting descriptive information. Here's some data on how the treatment sessions actually panned out. In the upper left-hand corner is all the patients' kind of session 1 and what happened in session 1. So the big tall bar in session 1 is that they got kind of an overview of what the family checkup is. A lot of patients also got the informed consent documents for our research process. 27 patients got the packet of information we need completed, the assessment battery. And then fewer also got parts of the assessment, including the interview, the completion of those rating scales, and video data. So, we kind of said earlier that I initially envisioned that most people would get a lot of the assessment in the very first session. It's kind of not how it turned out. Most people just sort of got information in the first session, and they were asked to come back. So then the middle box represents what happened in the second session, and that's when the bulk of the assessment strategies were deployed, videotaping, asking parents questions, completing rating scales. And then that third box shows the feedback session, which happened for most patients in yet a third visit. Now keep in mind that first box is commensurate with a well visit, so they were already in. It wasn't like we didn't bring them in 3 times just for the family checkup. We only brought them in 2 additional times. But it still is slightly different from what we had hoped. We had hoped that it would be 2 total visits, one kind of tagged on to the well visit, and then a second visit for the feedback and follow-up. That relates to, I think, some of our results. Here's some data on parent satisfaction with the family checkup, where 4 means agree and 5 strongly agree. Most of these items speak to the way in which the intervention fit into the system. So like were appointments scheduled on time, and were the support staff helpful, and things were well managed, and people were knowledgeable, and that kind of stuff. And we, by and large, did pretty well in terms of just the service delivery strategy, with pretty good ratings across the board there. Where we had slightly lower ratings were in terms of helping them get referred or to other needed services, and also actually solving their problems. And we had people generally agreeing that we solved their problems, but not like really ecstatically agreeing that we solved their problems. So it seems like we made some improvements, but not like wholehearted improvements. So this gets back to that issue I was mentioning earlier about integrating care, and that balance of making it work with the system and making it smooth and efficient in a population care model, but also improving the quality and making sure the quality is ideal. What time am I at?
12:48.
Lovely, thank you. So, I'll just say, commensurate with that data, that we have some very preliminary outcomes data that I didn't really feel comfortable bringing up here today because we're still kind of making sure that all the calculations are correct. But from what I can tell, we're seeing improvements from pre to post treatment for the patients that we're following up with. We've got about 10 patients that we've gotten all this data on so far, but we're not bringing them within normal limits. Again, that's also consistent with this PCBH model of providing people with a low dose of treatment, moving them in the direction of improved change, and then possibly, we continue to see them in primary care, right? Meeting with them again and again and making some gains over time. Remember, the alternate is referring them outside to a more intensive service. A small percentage of them will actually go. So all of this kind of relates to sort of this topic of sort of future directions and summary. The adoption was really high, and the reach was pretty good, especially compared to how the family checkup is done in other settings, especially compared to how well our reach would be if we referred all these people to specialty mental health. It would be much lower. What the evidence shows from the school-based studies is that the people who access the treatment are the most at risk in the sample. So out of all of those 26 kids that were referred, if it's true, if this stands up to what the literature has shown before with the family checkup, the 18 that we saw are the most at-risk kids. So we actually got kind of the neediest people in. It'd be great to test that out, but we didn't have that planned. We also kind of know now that most people ended up attending 3 appointments ultimately, and that wasn't our original plan. So just thinking about, well, how can we get better reach? I start thinking, well, maybe we should screen at other well visits. We could screen at 3-year-old visits. We could screen at 6-year-old visits. We could screen at 7 and 8 and 9 and 10 and 11 and 12-year-old visits because the family checkup is appropriate for 2 through 12 or 13. And if we're capturing 30 kids at each of those years, then we're seeing quite a few kids across the lifespan, and that would really be interesting. Another way that we're trying to improve reach is by leveraging social work to do home visits, and we could do more of that. We could try to get into the home for follow-up sessions for people who aren't making it back. We could, when we know that a 4 or 5-year-old is coming in for a well visit and they're a high-risk patient who's struggled in the past, we could just tell them, you're going to be here for an hour and a half. And we could preload the behavioral health consultant to start the family checkup with them Maybe if the provider's running behind. So some of that stuff is getting done while they're waiting, and some of it's getting done after. It's just part of what we do for all of our high-risk 4 and 5-year-old patients. We also could consider how we pitch the FCU. And so in the beginning, we really encouraged people to say, hey, I'd like to refer you to the family checkup. What if we stopped doing that? What if we just started saying, hey, I need to introduce you to my colleague. She's got some paperwork she wants you to fill out. We've got a treatment that we think can work really well for you, instead of calling it something distinct and separate. We could also strengthen our identification of appropriate referrals. So my behavioral health consultants and I were just sitting down a little while ago looking at the gamut of patients that they've seen over the last several months. And there were probably quite a few in there that could benefit from the family checkup. How do we know if maybe 8 or 10 or 12 or 15 of those people couldn't have been put into the flow, and we would have had even better reach? And then finally, well, I kind of mentioned this, but like standing orders to allow us to see patients in advance of the provider. If there's a little bit of time on the front end, people are waiting around. They could be filling out the rating scales. We could be doing some of videotaping with them. We could be getting some of the assessment accomplished. I think there's a lot of opportunity there to strengthen our reach just based on our capturing these patients that we're not doing. Satisfaction with the service delivery mechanism was high, very high. Satisfaction with the length and the results of treatment is good-ish. And our preliminary data on outcomes shows improvements, but not to within normal limits. So I think bolstering social work support for other needed services so we can expand what we're giving them, and then looking at how closely we're adhering to the treatment, what the fidelity of the intervention is, are going to be really important directions for us. This is kind of how I think we're fitting the family checkup into primary care. Like, we really just need to get the bumper in, and then we'll be okay, right? Here we are with Brandy again. I just bring this up because we talked about the breadth of services she's offering. And when you think about the family checkup and all that I've presented today, you may think, well, this whole study, and you got 30 referrals, and you saw 18 kids, and we've got this enormous practice. Like, what are the implications here? To me, it's like we have to think about this wide problem scope, because this is just one domain of many domains where we have some opportunity to engage patients in your practice, but also, this is the stuff that keeps me up at night. We have a wide problem scope, but we also have this like sort of dose of intervention sort of factor, where we want to provide more treatment to people who are greatest risk, and we want to provide like preventative treatments and even kind of anticipatory guidance to people who are at least risk or don't have any problems right now. So if you want to think about, if this was a grid with sort of representative boxes for all those problems and more, this is the little box we were addressing with the study. It was people who are at risk, and we managed to capture 40 or 50% of the people in that box, at least for 4 and 5-year-olds. But really, when you think about it, that behavior problems category has all of these boxes. There are those who seek treatment at the very bottom. Those are the folks that really need the help. They probably have even higher scores and even more need because they're coming out of their houses to find us, right? Then we have above that the people we addressed in this study, and then above that the people who scored high but didn't come back. Could we be doing something for them? Could there be a one-session adapted model? Or even a more brief version that we do for them? What does that look like? And then some of you had the chance to hear Dr. Gardner last week talk about, let's intervene with people who aren't having problems, okay? So that's where you get to the top here, and help parents in the first 1,000 days think about their relationship with their child. Think about how they're going to teach their child to handle emotions and all of the kinds of things that we know address toxic stress and promote health among children. So this is kind of the range of services that we are always thinking about. And I wanted you to see kind of where I feel like our results fit in this context and how they inform going forward. Questions? Ideas? This is a different kind of presentation because it's all brand new data. So like the real function of a talk like this is for me to hear like people's creative thoughts about how to go forward with this data. Yeah.
So since they're small bites of sort of behavioral health interventions, and like you said, you're not attempting to solve all the problems, just
Right.
putting them on a better path, do you anticipate saying, well, 6 months later, let's gather up those 18 patients again and do another family checkup with them to see where they are? The reason the question comes up is because I had a child whom I haven't seen in about a year come back to clinic and had some sleep issues, and behavioral health preceded me into the room, and in coming back and looking at the chart, they were actually ones we had referred to behavioral health and family checkup, and may have been one of the families that did complete it, and may have been better in somewhat of the domains that they had chosen to do, but were having issues with sleep. And,
Yep.
we're kind of back again, and before we realized that they had already been through the process, we actually administered a PSC 17 to them, and she scored the exact same number that she did the last time.
Back to the drawing board. And who knows, like it may be that that a lower dose like booster session at that point would be all that family would need to get back on track again. But I think that's the advantage of being in primary care. And at some point we want to articulate how we're following up with these families over the long haul. Certainly if they've been seen in the family checkup before, it would be a no-brainer to preload those patients for extra time at their next well visit a year later so that we can do that kind of automatic follow-up. It makes perfect sense. Scheduling them for 6 months might work too, but we just know that people are not good at coming back for those appointments if they don't need them. Other questions or ideas have come up? Yeah. Yes. I mean, I haven't personally. Yeah, we call that reverse integration, and that's what Cherokee Health Systems did. They were a community mental health service. They had multiple sites, and they reverse integrated primary care into those settings. I don't know much about. No, I mean, I know one of their sites it has multiple pediatricians at it in Talbot. So I don't know that that's completely true. Can you speak to that, Lindsay? Mm-hmm. Yeah. Dave?
Using the PSC, are you satisfied with that as a screening?
Not really. No.
Because in terms of trying to capture families that, before they get to, say, a disorder level
Right.
and have problems, I don't know that it has a sensitivity to pick those up. Should we be using a more sensitive screening tool? There's always a trade-off between length and sensitivity.
Right.
Should we be using a more sensitive tool and try and capture more folks within intervention, which is meant to be for folks that have less, don't particularly have disorders, they just have early manifestations of problems.
Right. Well, actually, it was developed for kids who are identified through screeners as at risk. So it's sort of a tertiary intervention of prevention strategy of sorts, but or secondary prevention, I guess. But that's a great question. I don't know the answer. Like on the one hand, sure, maybe it would be cool to start coming up with, and Debbie and I have even talked about this, like maybe some social determinants where we look at kind of family risk factors. And even if there are no behavior problems, we kind of bring in some of this stuff for families. Because it's hard to find kids when they don't have a problem. Then they don't have a problem. They're not going to come up high. And then how do we, the other thing I want to say really quickly is that we are in the process of comparing rates of identification and referral during 2015, during the family checkup, the whole year being in place with the PSC, to rates of identification and referral in 2014 when we didn't have the PSC and it was based on kind of the PEDS plus clinical judgment. and kind of looking at whether our rate of identification referral changed as a result of changing the screener. And I actually believe, and I don't have the data on this yet, so it's like a cliffhanger, but what I believe is that we're going to find no difference, because I believe that the actual most sensitive tool are the providers who, when we're talking about externalizing behavior problems, and parents who are stressed out and forlorn, are awfully good at identifying those concerns, particularly since they have help right there. If you don't have help right there, then you don't look for this stuff. But our providers have been trained to look for this stuff, and I think they work with the residents to get them to look for it and uncover it. And they're actually way more sensitive than any kind of number of items might be, is my belief. Now, that's different when you talk about like postpartum depression, because that's not something that is naturally part of a pediatric visit. So a screener there is invaluable. The PSC is reimbursable. So, you know, kind of doing that dance of, well, let's keep administering it because it's reimbursable and you're doing it anyway. Let's keep training our providers to have sensitive skill sets and keep our model such that they don't mind to uncover these things because there's someone standing right outside the door and it's not going to cost them 15 minutes or 30 or an hour to uncover it. And then I think you're right, like it would be great to have more sensitive screeners that are just part of our roadmap in the long run. Because I wasn't very happy with a 9% identification rate. I felt like we probably missed out. Again, they did refer an additional 9 kids that were not meeting criteria based on their own clinical judgment.
And if I remember, I think it was one of our follow-up meetings where we felt we were not identifying enough, and we said, can we use our clinical judgment
Yes.
when they come for a pharyngitis, saying, hey, let's administer a PSC
Yes.
to this child. We think that they may need
Yes.
intervention by you all. And I mean, it's sometimes very obvious. You go in the room and you look and you say, oh my gosh, they're going to be 22 on a PSC 17.
Yeah.
When you walk in.
You can guess
So,
the score.
yeah, you can guess the score. But I think, and then the flip side of administering it to all sick visits was the fact that they may really be there with 103 temperature, and it may be the totally wrong time to address
Yeah.
the child or the family.
Yes. For a brief time, we tried administering the PSC to all visits, and it was not a good plan. It was too many PSCs. It was people who were too sick to engage it. It was just so variable that we didn't do that. So, you know, continuing to identify pathways, I think that's some of what I talked about in my prior slides, and trying to figure out how to leverage this intervention, but also try to make the intervention even a little bit stronger and a little bit more robust. I think I might be out of time, but in any case, thank you all very much for your attention, and thanks for having me. Appreciate it. Thank you for your putting up with my very annoying sudden revelation that I needed my other slide set. And I made these last minute changes to it, so I was like,